Now we have a clinical trial that is also multi-center investigator initiated that I have the privilege of leading, where we're looking at patients pre-selected for DNA repair defect and then randomized prospectively to abiraterone or olaparib or the combination. And as I mentioned in my presentation, we are in an era where we're discovering different alterations in the DNA repair pathway, and the question comes up is, are they as relevant as BRCA1, BRCA2, and ATM? We can't obviously assume. Preclinically, there seems to be what I call shades of gray in terms of responsiveness in preclinical models to PARP inhibitors with these, and so we're sort of dividing the findings into two categories. Patients with what we call canonical DNA repair defects, BRCA1, BRCA2, ATM, are being randomized to the 3 arms, and then those who have the other alterations, we have an exploratory arm with olaparib as single agent to see if in fact they respond to a PARP inhibitor. As I showed also, there are at least 5 other, in total 5 drugs that are PARP inhibitors that are being evaluated in different phases in prostate cancer. Several phase 3 trials in single agents in the either pre-selected or not pre-selected populations. So these are registrational trials. There are also several other trials combining PARP inhibitors with other agents like immune checkpoint inhibitors, like with radium, with actually VEGF inhibitors. So there's different, with platinum. So there's different trials looking at different potential combinations also in there. And as I mentioned, there was some interesting out-of-the-box, what I call a thinking, in that there were several trials that are in the hormone-sensitive population that are testing single-agent PARP inhibitors in that setting to see if in fact there is potential benefit there. So there's a lot of work going on with the PARP inhibitors. My hope is that within the next couple of years we will have some answers.